Okay, well, people will no doubt join us, and people will also get this, which is being recorded and being live streamed, so it'll be available for others who have signed up but have maybe not been able to attend. So welcome to this event hosted by Doctors in Distress, which is a charity aiming to reduce the rate of suicide amongst all health professionals, not just doctors. And we do that by predominantly creating spaces where people can come together to talk about the emotional impact of their work. And we've got two wonderful speakers joining with us today. And just for some practicalities, we'll aim to finish no later than 12:30. It might actually be slightly sooner than that, depending on the number of questions. So just to explain who I am. So I'm the chair of Doctors in Distress, and I'm also a GP, and I'm very interested in the mental health and well-being of all NHS staff, mainly because I've been running for the last 14 years a service called Practitioner Health, aiming to improve the access that staff get to mental health services. Now, what we're actually planning for the nurses is very similar to what we did for our doctors. And what we do is this particular model where we have this introductory webinar followed by 8 small groups, and those small groups will be no more than 20 people in any group, and they will be fixed in a sense. In other words, after the first couple of groups, they will be closed. We won't allow new members to them. And it will give you a space with a facilitator to be able to talk about your experience of long COVID, but also your experience in general about how you've fared with the pandemic. We then will close after those 8 sessions by having a final webinar where you'll all come together again and just share your experiences and what went well and what didn't go well. So we'll get some those details of those at the end of this webinar. So let me first just introduce Lynn. Lynn is a healthcare assistant, and if you can look very closely, I've just been told those paintings behind her are of Malta, so I'm already adore her because many of you know both my parents are Maltese, and I associate myself with Malta, which is a tiny island in the middle of the Mediterranean. But Lynn is going to talk about her experience as a nurse with long COVID and the effect that it's had on her, and in particular, the effect it's had on her as a health professional herself. So Lynn, do you want to just tell us a little bit about what it's been like for you? And I'm just going to shut the window, but carry on talking.
Okay, thank you. Well, it's been a long journey. I tested positive in June last year, and I was actually in work and I lost my sense of smell and taste about 6 hours into my shift, and by 6 o'clock that evening I was sent home because I wasn't feeling very well. I tested positive the next day and I was off work. The symptoms I had were very severe in the beginning. It totally floored me. I was in bed for about 6 weeks. And then I thought I was feeling better. So after 8 weeks off, I went back to work. And I did 3 6-hour twilight shifts.
What's a twilight shift for those that might not know the shifts?
6 p.m. till midnight.
Right, so quite an onerous one.
Yes, I usually do nights, but I do days as well. And I was on day shift when I got ill. I was off for another 4 weeks, and then I tried to go back again. And I did 2 6-hour day shifts, and I relapsed again, had to go home.
And what were the symptoms that you relapsed into, Lynn? What was it predominantly? Was it the sense of smell or the lack of it, or was it tiredness or muscle pain?
The smell came on very quickly, but it was the pain and the fatigue. I didn't have no appetite. I couldn't eat properly. I'm diabetic. I needed to try and eat something so I could take my medication. Anyway, I had to ask the doctor for a blood test, and this was in October, and my iron level was 6, and my vitamin D was very, very low, so I had to have treatment for that. I haven't been back to work since. I can just about deal with looking after myself after so long. I mean, it's been just over 10 months now, and I'm still having new symptoms.
Like what?
About November, December time, I started with brain fog. I couldn't make decisions. I couldn't drive for 3 months. I had no confidence in even deciding whether I wanted a cup of tea or a cup of coffee. It was bizarre.
When you got COVID, I mean, you
Yeah.
said you were unwell for 8 weeks. What was the predominant symptoms of your COVID?
The nerve pain and the bone pain were exacerbated because I already have osteoarthritis, and at the moment I've had one X-ray on my jaw. I have a spur or something. I can't open my mouth. I'm on a soft diet at the moment, and the pain caused massive headaches, migraines. I developed tinnitus in my ears, and they said it was referred pain.
So that was
from
not related to that wasn't related to COVID, but that the COVID,
no,
if you like, just added a background
yes,
problem. Can I ask, being a nurse, I mean, not to sort of dob in your colleagues, but has your work been sympathetic? I mean, what's it? Because nurses are a bit like doctors; they're never real. You know, you have to sort yourself out, and you went back to do those shifts probably before you were completely better. Clearly, you weren't better. But what has been the response by work and your colleagues?
From my near work colleagues, they've been brilliant. They keep in touch quite a lot. The management have been as helpful as they can. They want me back to work, but I'm not fit enough. So that's the hardest bit, is trying to tell somebody how you feel.
Yes.
And I had very bad anxiety every time I had to phone the doctor for a sick note. And some of the doctors didn't, they put it down to anxiety and not COVID.
What sort of treatment have you had? I mean, have you just been left at home to get on with it? I mean, you mentioned had iron tablets and vitamin D, but
yes,
what's been suggested to you?
I have 3 consultant appointments pending, but who knows when I'll get them. They were only requested in December, so I don't know when I'm going to see. I've asked to see a neurologist because I believe my brain isn't working properly as it should. When I sleep at night, I get involuntary movements in my arms and legs. So I'm awake quite often, 2 or 3 times a night.
Are you able to drive now? Is that something that...
I started a month ago, yes, but I go just to the shops and back.
We're getting a lot of comments, Lynn. Thank you so much for sharing about your experience. And and that some people have had to resort to going private for their tests. Have you had to do that, or has the NHS picked up a lot of what's been going on for you?
As I said, I've got these 3 appointments, but I don't know when I get them. I haven't got the money to go private.
No, of course not.
I live on my own, so my work is the only income I have. But oh, sorry, I've lost.
Not at all. You're doing unbelievably well. It's a privilege to hear you talk, because I think we're all learning a lot more about long COVID, and I think more and more of us that have had COVID realise that we've still got residual symptoms, and probably like you rushed into fitness and wellness far too early. And it sounds like you rushed into wellness very early on. I mean, returning to work after 8 weeks and returning to a long twilight shift, which is not the easiest of all shifts to do, probably set you back. I mean, in your own mind, are you looking at getting back to work, or is that something that's still in a dim and distant future?
At the moment, I'm not capable. I can't trust myself to drive the car further than 20 miles. I've got no confidence in anything I do, and I still can't make decisions. It's shocking. I've worked 22 years in the hospital, and I love my job, but I am not fit. I've had a couple of incidents where I've messed up my medication. I've double dosed a couple of times. It's and I didn't know nothing about it until the next day when I went to get that day's and it wasn't there.
I suppose part of what we're trying to do, and what we did with the doctors' long COVID groups, is to let you see that you're not alone, because actually there are many other people in a similar position to you. Would you find it helpful to join the group that we're setting up over the next few weeks?
I think so. Yes, I do belong to 2 different COVID groups. I did a course for help to live with the physical part of the virus, and we made our own page, and we get together to meet up when we can and online, and that's so helpful, because you're not alone, because you've got other people.
And I think that's so important, because it's a very isolating illness if you're not able to travel and you feel that your mind is all a fog. And what you've shared with us, I'm immensely grateful, because even though I know you've shared it before on the BBC, where was that? Was it a news programme you shared it with?
Yes, it was called Wales Live on BBC One.
But I know how difficult it is still to talk about personal issues and personal. So I am very, very grateful to you, and many people are grateful. So somebody's put here, these other 2 groups that you've been on, are those accessible to others, or are they just closed groups for yourself?
I'm not sure, to be honest. I think they're specifically for, one of them is for North Wales.
Okay.
Yeah.
Lovely. Well, thank you so much, Lynn, and thank you from Doctors in Distress for sharing your story. You're more than welcome to stay. And I'm now going to interview Emma, who's actually at work at the moment. So again, I'm very grateful to you, Emma, for giving up your time to come to us. So Emma does some phenomenal work. She's currently a nurse, and she's leading on a national programme to reduce suicides in nurses and midwives. And we think sometimes that doctors have it bad, but nurses, and particularly midwives, have really high rates of mental illness, high rates of post-traumatic stress disorder, and sadly also high rates of suicide. So it's really important work that you do, Emma, and thank you so much. She's also a member of the expert advisory group and nurse representative on a national programme looking at providing enhanced mental health and wellbeing for NHS staff. So, and she's got lots and lots of other expertise, in particular around learning disability and autism. And I think you led that during the pandemic. But Emma, do you want to just tell us a little bit? I mean, I've given you a brief introduction. Tell us a little bit about your current role. What is it that you're doing around nursing, and is it just specifically for nurses? Emma, I think you're on mute.
That's an epic fail in the start, wasn't it? But firstly, I'd just like to echo your thanks to Lynn, actually. That was a very powerful and moving reflection, and very generous, Lynn, of you to share what must be a really personal and still quite frightening place to be. Mm-hmm. So my role, I've a couple of roles. So I'm in clinical practice, and I have been in clinical practice throughout COVID. 1 day a week, so minimal compared to many nurses who of course have been at that point of care day in, day out, many without a break for a long, long time now. And I have a national role around mental health nursing. I have a particular interest because of that around nurses and welfare and how we look after ourselves, but more importantly, how we look after each other. You mentioned there about the work that I've led around suicide prevention. And also that I held a clinical lead role as part of the COVID response around mental health and the learning disability, but also thinking about the mental health of nurses and the wider workforce. And to frame that a little bit as to why that might be important when we're talking about long COVID, which of course is not a psychological condition. It will have psychological impact, and there will be psychological or psychiatric aspects to it. We know, for instance, that some recent research has suggested that there is an increase in psychosis following a diagnosis of COVID, for instance. So we know that it does cause some psychiatric conditions potentially, but it's more that we know that pain, just as Lynn spoke about, that the physical health conditions for any of us have an impact on our psychological health and well-being. So it's about linking the two. One of the first things that I did when we knew that the pandemic was about to hit, if you like, was to look at some of the international evidence about how the workforce was impacted following previous pandemics. In the UK, we've largely escaped that. But of course, our colleagues in Asia and globally have unfortunately had Ebola and SARS. And we knew from that nurses are disproportionately impacted following any pandemic, both from their physical health, but also psychological health, and the two. So we knew that even before we understood the impact that COVID might have on people longer term, we knew that nurses particularly were likely to be impacted. So I was always really committed, alongside lots of other colleagues. This hasn't been me on my own. This has been a huge team approach and a collaborative approach across particularly England. So I'm going to be talking from a very England perspective, but I know that my colleagues in Wales, Scotland and Northern Ireland across the UK were also thinking about what could we put in place, knowing that nurses are more likely to be disproportionately impacted.
And we'll pick up on that in a minute, and you're absolutely right. SARS, Ebola, even the early days of COVID in Wuhan, we forget that it's nurses who are most at risk and most affected, and actually in a way have less authority to remove themselves from risk, which, you know, when you're on a shift, you're on a shift. But can I just backpedal a little bit, Emma? I mean, I'm interested in you, and why did you become a nurse? Just tell us a little bit about you.
So it's an interesting question, why did I become a nurse? Because it's not something I particularly aspired to growing up. I thought I was going to be joining the military, actually. But life throws different opportunities at you. And I actually took a year out after my A-levels, and I worked as a nursing assistant, as they were then called, in a home for people with what was called elderly mentally infirm. We'd now probably refer it to as dementia. Hopefully we'd refer it to as dementia rather than elderly mentally infirm. But I absolutely loved it. It was really hard work. I will often say it was probably the hardest I've ever worked in my life, before or since, in terms of physically and mentally. But I really felt like I'd found my place, which probably sounds a bit of a cheesy thing to say in many ways. But I really felt not comfortable, because as I say, it was really, really hard, but I could see, and I really admired the nurses that I was surrounded by and the other nursing assistants, how care, compassion, how often the smallest things can make the biggest difference. And I wanted to do that. I wanted to be part of that. And so decided a complete sea change. It was a complete shock to everybody that knew me, because I think I was probably the most least likely. I was a bit of a tomboy, out and about, water sports, very, very active, never showed any interest in doing anything like that before. So it really transformed my way of thinking, and I've never looked back, actually.
What a lovely story, Emma. So, I mean, caring for what must have been the hardest group of patients then and even now, if these were elderly patients with dementia. And I know my father had dementia, and it's a really difficult space. And yet what happened, that this young girl, which of course you were then, just fell in love with this caring role. But presumably it was always there. It's just it had never been expressed in a way. And
yeah, I think you're probably right. It's only when you look back and reflect, isn't it, that you realise that probably there was this path that was set, particularly around mental health. I have got experience in my family around mental health and suicide, particularly, and family members with learning disability. And I suppose it was always set there, but you kind of push it aside, or that's just the way you are, or that's just what we do around here. So you don't really recognise it perhaps as a skill set or as an aspiration. And as you say, it had a bit of an awakening when I was then put in a place where I could see not just the impact that I could have, but the impact others have and the difference that you can make. And I learned as much from those people that I cared for as hopefully I made a difference to them. It was, yeah, really, yeah, as I say, transformational time. It is hard. The thing I think I learned there was also how hard it is for families and carers. And I think that's what always attracted me, that sometimes it wasn't just the people you were looking after that impacted, it was very much their families.
And you talk with such compassion still, and it's so lovely to hear that. I mean, but it's tough being a nurse. And how, I mean, you mentioned that you've been working clinically as well as sort of in leadership and operational work, but how have you found the pandemic yourself as a nurse? How have you found it in the clinical role rather than, although very, very important, other bits?
It's been an interesting dichotomy between the two, actually, sort of holding them both in mind. So I know originally when we knew the pandemic was going to hit, I wanted to go straight into clinical practice full time, if I'm honest. I would have rather just hung up the national role and got into my uniform and gone to help on what, you know, it has been referred to as the front line, which I don't really like that language, but I think people understand what I'm saying. And there's just a real urge to want to be at the face of it. And I think lots of nurses felt the same, and lots of nurses that I spoke to at the time and speak to now, there was this real urge for us to go to the front and care for people without probably understanding what the impact might have on us and our families. I know at the beginning it was a feeling of fear, actually. I remember being really, really worried that, particularly because as a mental health nurse, that when we were thinking about how we might have to think about how we cared for people, that there might be people that wouldn't get the care they would need. And I remember being really fearful around that and frightened about what we might find or what we might have to neglect, I suppose. Clinically, it was a real shift in practice. I work in an acute hospital, supporting people who come into hospital who have mental health problems, or because of their physiological problems become mentally unwell. And there was a push at first for us not to see people face to face. And I really struggled with that, actually, because the thing that I've always valued, I've always maintained clinical practice throughout my career in various places. And I really, although I completely get the benefits of our virtual working, to me, you can't make up for physical contact, physical touch, and you can't underestimate how important that is for people. So I really did struggle when there was quite a push for us not to have physical face-to-face contact, because that really has been the cornerstone of my practice, has been that the therapeutic use of touch, the reaching out. So it was a feeling of fear, of being overwhelmed, not knowing how to make the biggest difference, feeling that you're never making quite enough difference. You know, it feels like you couldn't quite do enough at different times.
A sense of guilt, which is described by many people's experience, health professionals' experience of COVID, of working in COVID, that you can never give enough of yourself, and that must and letting people down seems to be an overwhelming, but it sounds like it's a sort of existential fear, because actually you gave so much of yourself and you still do. How have you protected yourself? I mean, how have you stopped or maybe you haven't stopped the trauma sticking to you and the work sticking to you over this pandemic?
Yeah, I think I would say that I haven't always got the balance right. I think that would be fair to say. I think particularly in the early days, it was really difficult to take any time off at all. I remember working, as many of us did, 7 days a week, waking up in the night. I don't think I slept properly for about 7 or 8 months, if that, even dreaming about COVID or what else I could do, shouldn't do, worrying, was I bringing it home? Didn't see any family or friends even when we were allowed to, really, because I was worried that I would pass it on or they might give it to me and then I wouldn't be able to work. So I would say that I haven't always got it right. And there's been different moments. So I've really reached out to the people around me. I'm really lucky. I don't live alone. I really can think for Lynn how difficult that must be to live alone. I'm lucky. I have a husband at home. I had my sons at home who are quite grown up now, to give me that balance and tell me to get a grip, if you like, sometimes, which is what you need, and take some time out. I run, so I kept running, if you like it, not very well, but really going out into fresh air and trying to take regular breaks. But it has been hard because all you can see around you is a need to do something, and that is like an existential urge almost, and it can be hard to role model. And so I've thought much more about that I can't be seen to be the lead or a key influencer or leader around mental health and well-being if I'm not practicing what I preach. So it takes effort.
I suspect it's been very difficult to practice what you preach. I suspect many people are guilty of not doing the same. And because I know how hard you've worked, because I think we bumped into each other virtually over this pandemic, and what amazing work that you've been doing over this time. Doctors in Distress aim is to set up reflective groups, not necessarily, they're not fixed on any particular model. So it can be what's called a Balint group, where you bring a patient and discuss issues around the patient. We also reflective practice groups, narrative breaks. Somebody's got their mic on. You're probably at work, aren't you, Emma? So different sorts of groups. And so in order that people can just talk about the emotional impact of their work and talk about what their work means to them, but also some of the difficulties. Is that something that you've got experience of, Emma? Is that something you would welcome, that would be accessed by all nurses and healthcare assistants, and in order that we can actually not feel so alone?
I think having safe spaces, and I use that word, where people can feel comfortable, can feel that others are going to really listen to what they say, because sometimes you can have conversations and they're rushed, people aren't really listening, and having to be able to talk spaces with other nurses, I think, is critically important. So very similar to probably other professions, and I know doctors, is that we respond better when we're surrounded by our own profession. We feel better understood. There can be a lot of fear about sharing, because we don't want to look like we're not coping, or that we're not strong, or we're not doing what we're meant to. So it does need to feel a safe space, and that can be a bit of a barrier. But it's so important that it's acknowledged as a need, and that people are given the space and time.
Yes, absolutely. And I'd just like to say to folk who are listening to this, Emma's at work, so the reason you hear noise is, I suspect, people around her having to do. But the one striking feature of this pandemic is how little silence there is. I don't know, everybody must experience this. You're trying to find, 2 minutes to do a live interview, and suddenly sirens go by or doors shut. And it's been my experience, and I suspect many others, how much noise we live in and how difficult it is to stop that noise, no matter what we try and do. So thank you for doing it at work, Emma, but I think gives a real life experience. So just sort of drawing on to the impact of the pandemic, and with your sort of national lead role rather than you as Emma as a nurse, what do you think has been the impact for nurses and midwives and healthcare assistants of the pandemic on their mental health?
I think it's had a huge impact. There's several aspects to it. One is that not only the work's hard anyway, we have a huge emotional toil and emotional burden that we carry as nurses. We're seeing people at their most vulnerable, they're most sick, they're most exposed, and we soak that up day in, day out. And we do a fantastic job of that. I think what we can normally do is we can go home and we can relax, and we've got really strong networks or coping strategies around us. And of course, the pandemic closed that down. So those normal aspects that we would be able to focus on, we haven't been able to. And COVID is everywhere, isn't it? It's infiltrated our personal life, our professional life. There's been huge scrutiny, which makes it incredibly difficult. But the other thing that's most significant is that we haven't always been able to deliver the care we want to in the way that we want to. We know that our practice has had to shift to be safe. So lots of us have had to work remotely where normally we'd be seeing face to face, and that, you know, that goes against the reason a lot of us came into nursing. And in other places we've been stretched. So we know that there are nurse shortages, there aren't enough of us, and we've had to care for more patients than we might normally had to do. So it's meant we can't have the breaks that we would have. We haven't been able to have the time off. And all of that combined, as well as a fear of becoming unwell or a fear of spreading COVID to our families, creates extra anxiety and stress.
Lynn, do you feel a sort of guilt about you not being at work? Is that something that worries you as well?
Yes.
Tell me a little bit more.
It's hard when I go out and see colleagues and they're busy getting ready for a shift or something, and it makes me sad. It really does. That's all I've done for the last 22 years, and not to have it.
So the strange thing, it isn't strange, is we've got Emma feeling guilty because she's not doing enough, and you feeling guilty because you can't do enough. And it seems as if guilt is, and I'm sure people, again, who've become unwell, is my experience of health professionals, is when they become unwell, they feel guilty for it, as if somehow it's their fault. That if only, you know, they didn't catch the virus, they would never have become unwell. I mean, Emma, is that something that you're experiencing amongst the circles that you're in, the debates, this overwhelming sense of guilt that people are carrying around them?
Yeah, there's a huge amount of guilt, and I think some shame as well, that people don't feel able to cope and manage. So you feel guilty because you feel like you're letting people down, and then shameful that you can't do as much as you think you should be. And so I see that and hear that a lot, actually, in combination of the two. And obviously there is a stigma around COVID. So I think particularly in the early days, it was felt that you perhaps hadn't protected yourself enough. If you caught COVID, that you had done something wrong, and I certainly know for nurses, we were accused of being super spreaders.
Yes, I do remember that. Somehow you were not only to blame for the overwhelming work that was happening in hospitals, but somehow people were blaming you for spreading COVID.
Yeah, and so you've had that fear of bringing it to your family, so that you were perhaps spreading it in hospitals to patients, because inadvertently you're trying to do your best. But this is a very tricky disease to contain, as we know, as we wouldn't be in a pandemic. So you have all this mixture going on around fear, shame, guilt, and blame, actually, because there is this element that actually you caught COVID because you've done something wrong.
Yes, we've got a few questions coming up. I'll ask maybe Lynn. There's someone that's just, somebody called Rachel, she's given her name, and she's struggling with 2 young children. She tested positive in October, still struggling on a daily basis, and has been off work ever since. And she's got chest pain, tiredness, and shortness of breath. And also this brain fog that you describe, where she said she set fire to a brand new toaster, dear. I mean, you mentioned that you've been referred to three people, but in your experience on these groups that you're on, has there been any beneficial treatment that's been offered to people that's got them better? And I will add to that with our doctors group, we had overwhelming feedback by large numbers who actually said it helped their recovery, just talking about it, being feeling that they weren't alone. Clearly, it didn't sort out all the problems. But have you, in your travels, Lynn, found anything that people have talked about that really helps?
A lot of people have been reporting on our group that they've been refused an appointment with a consultant when they've asked for one. The consultants have refused to see them for some reason.
But has anybody found something that helps? That actually has improved their symptoms?
Not that I can remember.
No.
The pattern of the virus is you'll have a couple of bad weeks, and then for a day or two you will feel really good. So you make the most of it, but the next day it's all back again. It's back to square one for a lot of people. It's never ending.
Well, the same question to you, Emma. Is that something? Have you found anything that helps? I mean, or is this something that is just a gradual improvement over time?
I think the issue is, and I'm not an expert on long COVID, so I'm not going to pretend to be, but
I'm not sure there are any experts, so
I was about to say that's the problem. That I think it's such an unknown disease, illness, set of symptoms at the moment that it's incredibly difficult because it is such an individualized experience in many cases. So therefore, understanding the course of the illness and how long it might last is really difficult to predict. And I think that feeds into the uncertainty for people and that feeling of hopelessness. So I know what I hear is that it's that uncertainty, it's that fear of not being believed, that actually what is incredibly powerful for people is someone actually acknowledging that there is something wrong, that it's not in their head, that this is a real thing. We may not have the answers, and I'm sure there are a combination. We know that we have huge investment in this area. There's research that's investing. Obviously, it's not working quick enough for the people that are experiencing such horrific things now, but just acknowledging that this is real, this is something, this is an issue that we're going to support people can only be of benefit. And I know that the nurses I've spoken to, some have recovered and actually recovered really well. And perhaps there's something about us being able to share those stories too that will evoke hope in others that, there is a way out. But for many others, it's just knowing that people are listening, that they acknowledge it, and that they're here to support them as best they can, that will be important.
And it's like a lot of illnesses that are medically unexplained, that we don't know what the cause is, that people feel shame because they think, well, I must get better, I've got to get better, and they tend to rush into getting better. But also, as you both described, there's this sense of disbelief by those that you're going to. I mean, Lynn, you said that people weren't allowed to go and see consultants. Certainly in the groups that we ran, what really helped was the acknowledgement that these are real symptoms. The fact that we don't know what the cause is irrelevant. They're real symptoms causing real disability. Emma, what do you foresee the effect on the nursing community will be on the fallout of the pandemic? Do you think, is it like medicine, that there's been an enormous increase in people applying for nursing? Is it, or is it again like we're hearing people wanting to leave because they're exhausted? What do you think the impact of this is going to be?
It's been a real mixed impact, and what you've seen in doctors is very similar to what we've seen in nursing, and that we have seen a huge increase in interest in people applying for roles. So in some ways, we've had the best in terms of recruitment, as people have really wanted, they've understood what the NHS does perhaps a bit better, and they wanted to be part of that. So we have had record numbers of people applying to do roles such as Lynn's, healthcare assistants and support workers, who are absolutely vital to the NHS. We've seen an absolute bumper year in terms of students, people wanting to train as nurses. So we've had, in terms of people apply last September, we had more nurses apply than we have done for many, many years. And particularly in mental health, we've seen a huge increase, which of course I'm absolutely delighted about, because we have got the biggest gap at the moment in terms of spaces. But of course, it's going to take time for people to train and qualify. So we're not going to see that benefit straight away. On the other hand,
the clapping for nurses, do you think that the clapping for the NHS, do you think that helped? I must say I found it a little bit embarrassing myself, but
personally, I hated it.
Yes.
I didn't want to go out in the street to see it. I found it, particularly in that heart of the pan. I know that the idea behind it was well-meaning,
Yes.
but personally, I didn't like it, and I know colleagues found it very disingenuous later on, actually, and didn't perhaps to say, but I think there's been positives and negatives from the pandemic for nursing. There's some obvious ones around tiredness, exhaustion. We have had many colleagues who have died, and that needs to be acknowledged, just because they have gone to work and done their jobs. We have many people that have been traumatized. We know that from research, from what they've had to do effectively, and we need to look after them. But we also know that it's had huge impact in that I think nurses have acknowledged that we need to look after ourselves better. And
Absolutely.
health and well-being, and that wake-up call has been really significant for nurses finally being acknowledged for the emotional burden that the work is before COVID, and a real commitment nationally to do something about that and make sure that we support people better now and going forward, actually. So I think it's mixed.
I think it's mixed, and of course both of you are unbelievably hardworking, and I suspect the clapping for the NHS you would far rather, I mean, it was embarrassing to start with. It then became, as you said, slightly intrusive, but I suspect what we really want for nurses is good pay, good conditions, and acknowledgement of the hard work you do. Isn't that right, Lynn?
Yes. Yeah. Oh, sorry.
Don't worry. You've done incredibly well, and we're really, really grateful. I'm going to draw this sort of interview a little bit to a close soon, because Chris has joined us. Emma, is there anything else you'd like to add about what I've asked you? I mean, you think the impact of nursing is positive and negative overall? Do you think it's much more positive than negative? The publicity, the unbelievable work nurses have done, the unbelievable positive publicity. I know that in the early days there was a lot of aggression towards nurses, and as you said, blaming you for being super spreaders, and I know in one part trying to steal passes, thinking that nurses are getting more benefits than non-NHS staff. But overall, do you see that the pandemic has really put nurses in a positive position? We start to value what they're doing.
I think overall, if you looked at it as a collective, then actually this has been positive. It really demonstrating the skill, the depth of knowledge, the compassion, the courage, the persistency that all nurses face day in, day out and continue to do. I think on an individual level, though, this has had inaudible impact. And I guess it's balancing the positive for the profession against the negative for individuals, and making sure that we continue to look after the individual. So I kind of hold the two in mind, that as a profession good, but individual probably there's been some negatives that we really need to reach out and make sure that we look after them.
And that's a sort of perfect segue into the next stage, which is looking at the groups that we'll be running. But I'd like to thank both of you, Lynn and Emma, for fabulous contribution. Emma, for the really, really hard work that you've done over the last 18 months, and what you're doing to support the mental health of nurses. Not just nurses, actually, you're involved in the space that all health professionals are discussed, and also for your continued work as a clinical nurse. And Lynn, thank you for giving your experience of long COVID, and I really hope that things begin to improve, and that maybe by the end of the 10 weeks of these groups, you can come back at the last webinar, say things maybe have got a bit better. But if you want to just both hang on, or you put your mics off or whatever, while I just bring in Chris. And Chris is a group analyst. For those of you who don't know what a group analyst is, it's somebody that's specifically trained to understand what happens in groups, and to use the dynamics in a group to actually not just affect and treat the individual person, but to allow the group, if you like, to support and heal each other. So it maximizes the chances of people improving by using the strength that's contained in the group. And Chris has been one of the facilitators on our long COVID group for doctors. And I just thought we'd spend a few moments just talking about the group that you've been running, clearly in general terms, Chris, because you're not going to talk about very specific things, but what did you see as the benefit of the group? And were people forced to share things that they didn't want to? I mean, just give us a little bit of your experience.
Hello, and thank you, Claire, for bringing me in. Yes, well, I suppose to start off with, I would say nobody gets forced to say anything. And although, of course, it can be difficult to feel the internal push to say something, but also the pull not to say something, those can be almost equal, can't they, when we join a group? But of course, the groups are set up to bring benefit to the people who participate. There'd be no point otherwise. And to reduce suffering, both things, bring benefit and reduce suffering. So how would that come about in a group? Of course, professionals, healthcare professionals work in groups and teams all the time. But it's very different, isn't it, when we're in our professional space? We choose to make a bit of a connection with someone else, but we don't bring much of ourselves on a personal level. And that might be the way in which some people would engage with this sort of group, but hold quite a bit back and really do more listening to others and not saying very much themselves. And that would be fine. You know, going back to what I just said, there's no expectation people will come and they will talk. But what often happens in these groups is that trust starts to develop a bit after everybody gets a good look at each other. And there's the opportunity to really make a connection in terms of shared experience. These things have happened to me. What happened to you? Some of it's similar, some of it's different. And both those things can be helpful in thinking about processing the trauma, because it is trauma. The pandemic has produced a lot of trauma, a lot of illness, physical illness, of course, but also the psychological trauma of being broken off from what was normal life. Remember that, normal life. So sharing over time can really bring back some sense of a direction.
And of course, you're absolutely right about broken. I mean, Lynn, when she was describing loss of work, I mean, the loss of purpose in that respect, because work gives you much more than pay. Are those the sort of common themes that happen in these groups? The sort of, once, as you said, I love the phrase you use, once people have got an eye open for each other and see what each other are these, can they trust the group enough to start talking about the real pain of losing work, losing friends, losing fitness, losing a role?
I think my experience has been that mostly yes, and to varying degrees, because everybody has their own personality, and some people are naturally more private anyway than other people who feel more comfortable in talking. But I think the way that groups work is that once something gets brought in, like what it's like to lose your job or lose your health, there's a kind of universal sense of being able to think and hold that issue, that problem within the group, and people relate to it in whatever way is right for them in that moment. I think the other aspect is, of course, the sense of see you next week.
Say a bit more about that, Chris.
Well, I think where people in the groups have found themselves, there's an enormous break of continuity, whether it's the daily routine, family life, and so on. And so to be able to say, see you next week, you'll be here for me, I'll be here for you, and we can pick up again, having had time during the week to think about what happened in the group and what we might have liked to say but couldn't say then. We might be able to say another time.
And absolutely, the fragmentation of our lives. I'd never really thought about how powerful it is to say, see you next week. I used to think that as a GP, to be able to say, see you next month, you know, ring me when, you know, for an appointment in the future, because our lives are so, now as I said, fragmented, so discontinuous that so the group provides some stability and safety. What about confidentiality, Chris? I mean, if you've got 10 people, 20 people in a group, how is confidentiality maintained?
Yes, well, confidentiality is a really important issue, isn't it? Who's going to want to speak about anything if they think might be talked about somewhere else? I certainly wouldn't. I think it's absolutely crucial that we start at the very start, we set our shared commitment to whatever's talked about in the group stays in the group, because it's not going to work otherwise. And so, of course, that relies on trust. But, you know, we're a group of professionals. We already know a lot about confidentiality. And I think, you know, group members need to know and to be able to avail themselves of that confidentiality, you know, for themselves. So it's very important.
And I'm assuming that people who attended the groups suffered from similar experiences that Lynn's suffering. We've seen it as well. So sadly, this sudden sense of not being able to think through something, of not being able to hold a complex sentence and or a question. I'm assuming that's also part of the group, and people can identify as others having that, and you know, sharing certainly provides some sort of respite to their loneliness of having these symptoms.
Yes, yes. I think given the way the groups run, of course, there's a variety of different ways in which COVID has affected different people in the group at any one time. But there are, as I said earlier, there are similarities, and one of the things that I think has applied to in every group that I've run is at some point someone will say, I've lost my thread. Well, of course, that's normal, and particularly after a certain age, I find, you know, oh, what was it I was saying? But it's, you know, I mean, but it's not funny when that's happening to you and when you're used to having everything at your fingertips. But there will be other people in the group that get that, really get it, because they understand it, they've experienced it, and they know the consequences of that, how it shakes your foundations.
And of course, groups, I started by saying it's not just that you can get support from a group, but the group members can support you as well, and that must be very therapeutic.
Yes. Yes. I think, you know, what I've observed is, because people don't take off their hat, you know, and I'm no longer a healthcare professional, in the group, people can't stop themselves reassuring each other and supporting each other. Of course, there's nothing wrong with that. And it can feel that that's both welcome to the recipient, but it's also, oh, yeah, I can still make a contribution, you know, by listening, which is, you know, part of my job. I can still make that contribution in terms of understanding and helping someone. So it is very much a reciprocal process. But if you come one week and you think, actually, I just can't take on anything that anybody's saying, it's perfectly okay to sit there in silence for the whole thing. People do that. It's absolutely fine.
Lynn, you've heard a little bit about the group. Is there anything you'd like to ask Chris? I mean, does it reassure you, if you were sort of, you know, to attend, that this would be a confidential space that was there to support you rather than, you know, anything else? It's not there to, it's not a PowerPoint presentation on the effects of long COVID.
Yeah, it's the group, one of the groups that I belong to. We do chat about everything that we wouldn't say on, you know, on the podcast. So it's very much a Facebook say, you know, we have a closed group, and we're all thinking the same thing. And we do get a lot of comfort from knowing that somebody else would finish my sentence and it would make sense, you know. It's wonderful.
And a problem shared is a problem halved.
Oh yes, definitely.
And Chris, have there been any surprises running the groups for long COVID? Any surprises that you've come across?
I don't know about surprises, but one of the observations that I have made is how we find, and this does happen in groups, but it's happened a lot in these groups, is that people want to talk about their experience now. Of course they do, because isolation is a big part of the experience of long COVID, isn't it? You know, so that coming together and talking about what's happening now and what's happened in the last year or so. So that's part of it. But then there's also moving into, you know, what I take from where I am now and what I might want to do differently in the future, a lot of which is more self-care.
Yeah, absolutely. So we're drawing to a close, but I just want to bring Susanna in, if that's possible, to tell us about practicalities, because there have been several questions about practicalities. And the groups are open for, if any of you want to tell your friends about them, Susanna will tell you how to get in contact with us. I mean, they're open. In other words, anybody, any nurse, healthcare assistant, anybody that's a midwife can join these. As I said, further down track, we will, once we form the groups, the smaller groups, we'll close them so that they become a confidential, smaller space for people to get to know each other. And they will be run by trained facilitators. Chris, as I said, is a group analyst, and they will be boundaried by time and space, and they'll all be online. But Susanna, do you want to say when they're going to be and a few more details and how people can get in contact?
Yeah, definitely. Thanks, Claire. So if you've already signed up for this webinar, which you will have done because you're here, you will receive the Zoom details to join the link, to join the groups. We're going to be holding groups starting on the 25th of May, every Tuesday at 3 to 4:30 p.m. If for whatever reason you haven't signed up, we will repost the links out on our social media on Twitter, Facebook, Instagram. We can also email if you want to drop your email in the box if you don't use social media, and we will make sure that link is sent to you. But please share this with anyone who's a nurse, HCA, midwife that you know who has long COVID, because we do believe that it will be a really brilliant support. So I think that's everything, Claire.
Thank you very much. No, that's absolutely fine. And people have the email, and we'll and we need details of the website. Do you want to?
I'll put it in there.
Put it into the chat box. Now, if there are any other questions from the attendees, I'm just going to put the website and the address, but I will just sort of, first of all, whilst Susanna's writing the website, I'd like to thank Chris, Lynn and Emma. Chris has been an absolute gem in helping us with the Doctors Long COVID groups, and has given more, as many people give more of themselves, and Emma and Lynn, you will have, than you receive, because I know that you've offered support and you've really held some people who are really quite distressed in those groups, and I'd like to just thank you for that, and also thank Lynn for your fabulous contribution. And there is as I said, the groups are free, the groups are there for you, and I really hope that others will join and that we can offer support. Now, just give it another minute in case there's some questions. There is a question: do you foresee the effects of nursing? But I think we've dealt with that one. So on the chat box, and we will email it to you, is the email address for Doctors in Distress. It's actually doctors-in-distress.org.uk. So on that note, I'd like to thank Chris, Lynn, Emma, Susanna, and the rest of the Doctors in Distress team. And thank you so much for all your hard work. And some of you will be returning in 2 weeks in one of the groups. So thank you.
I look forward to it.
Thank you very much.
Yes.
Thanks, Susanna.
Thank you,
Bye-bye.
everyone.
Thank
Thank you.
Bye-bye. Bye,
Bye.
Lynn.
There we go.
Thanks a lot.
Ooh.
I think there's still folks. Thanks very much. See you soon. I'll ring you back.